I would like to welcome you to the CHCI Health Summit session on innovation for detecting and treating Latino mortality. My name is Elizabeth Alvarez, and I am a first-year medical student at the University of California, Davis School of Medicine, and the 2017-2018 CHCI Graduate Health Fellow for the Office of Vice President-elect Senator Kamala Harris. On behalf of CHCI, I would like to thank Gentech, Grail, Novartis for their generous support of the session. Heart disease and cancer in Latinos are the two leading causes of death. This session will examine how we can save lives through early adoption of safe, innovative, and effective technologies that facilitate early detection and treatment. To lead this discussion, it is my privilege to introduce to you Congressman Eric Swalwell and our moderator, Maria Thacker Gothi. Eric Swalwell in 2012 was elected to represent California's 15th congressional district, which includes a large part of the East Bay. Now in his fourth term, he is working hard to bring new energy and a problem-solving spirit to Congress, with a focus on advancing policies that support equality, opportunity, and security. As a supporter of the Affordable Care Act, Congressman Swalwell works to strengthen and improve it. He has supported the funding of research programs at the National Institutes of Health and other agencies key to improving outcomes for patients and reducing costs in our healthcare system. We are honored to have a moderator who is a leader in this industry. Maria Thacker Gothi. As President and CEO of Georgia Bio, Maria has over 14 years of experience in nonprofit management and development. She has helped build the organization into one of the top state bioscience and medtech associations through her community outreach engagement, member development, and leadership programs to increase community connections and resources. You can contribute to this discussion on social media with the hashtag CHCI Summit. Now please welcome Congressman Eric Swalwell.
Hi, I'm Congressman Eric Swalwell, and I want to thank the Congressional Hispanic Caucus Institute for convening this very important summit. You know, the health disparities that Latino Americans face remain formidable. Higher rates of diabetes, chronic kidney disease, liver cirrhosis, and other diseases. But early detection and treatment of these diseases is key to improving Latino lives. The first step in achieving this early detection and treatment is insurance. Despite great gains made under the Affordable Care Act, Latinos are still more than twice as likely to be uninsured than white Americans. We must protect and expand that law so that every American is insured and has access to diagnostic, preventative, and therapeutics that they need. But medical innovation will play a role too. That's why I introduced the bipartisan Advancing Access to Patient Precision Medicine Act, which would push forward use of genetic and genomic testing to improve health management and save lives. Innovation in genomics has presented new opportunities to diagnose and treat genetic disorders, like some cancers and many rare diseases, or to predict the predisposition to a disease. So genetic and genomic tests can be the emerging field of precision medicine. We need customization of healthcare with medical decisions, treatments, practices, or products tailored to the individual patient. My bill would also pilot test whether Medicaid coverage of a variety of types of genetic and genomic sequencing for children can help settle their diagnostic challenges, improve clinical outcomes, and ultimately reduce costs. America's future chances to stay healthy will be limited unless patients have access to affordable healthcare, such as precision medicine testing. So this year, to achieve that goal, I worked with Senators Kirsten Gillibrand, Kirsten Sinema, Senator Tim Scott of South Carolina, Republican member Representative Tom Emmer, to launch the bicameral, bipartisan Congressional Personalized Medicine Caucus. We're working across the aisle to raise awareness and support for replacing our one-size-fits-all healthcare system with one that's customized to each patient. Our approach to healthcare should be as diverse and individualized as the patients they serve. As we do this, we need to expand our medical toolbox. We need robust funding for the National Institutes of Health and other institutions for cutting edge of medical innovation and technology to develop the tests and treatments of tomorrow. We must commit to bringing America back to world leadership and pioneering new, better medical techniques and therapies. And we must take our place among the world's modern nations to invest everywhere we can in therapies, regardless of someone's background, or income. We've seen the cost of ignoring science in this pandemic. It's American lives. It's time to invest in science and medicine to close our health disparities and bring longer, healthier lives for all. Thanks so much again to CHCI for convening all of us on this important topic.
Great, and thank you. Good morning, good afternoon, excuse me. My name is Maria Thacker Gothi, and I'm CEO for the Center for Global Health Innovation and President and CEO of Georgia Bio, based here in Atlanta, Georgia. I'm delighted to be your moderator and for a thought-provoking and insightful discussion on how technology can help us decrease the rate of Latino mortality. First, I would like to thank Congressman Eric Swalwell for his insightful remarks and setting the tone for our conversation. And thank you to CHCI for hosting this critical discussion on health issues facing our nation and communities. As most of us know, Latinos often lack access to health care and have poor health outcomes. This community has been disproportionately affected by COVID-19, with almost 3 times as many cases per head among Latinos than among whites, and hospitalization rates 4.6 times higher. But the specific challenges faced by Latinos in terms of health outcomes and healthcare access long predate the pandemic. Continued work towards health equity, improved health system strengthening, healthcare expansion, education, and communications are some of the things that will help combat this, but innovation plays a huge role. Now, throughout this discussion, I want to make sure we hear from you, our audience, so please place your comments and questions in the chat feature. You can also continue the conversation on social media using hashtag CHCI Summit. So I'm delighted today to be joined by 3 subject matter experts on this topic. Dr. Ruben Mesa, Executive Director of the Mesa Center at the UT Health San Antonio MD Anderson Cancer Center. Dr. Robert Stokenbrook, Medical Director for the Cardiorenal Metabolism Unit at Novartis. And Dr. Josh Offman, Chief Medical Officer and External Affairs Lead for GRAIL. So welcome to this panel and thanks for joining us. So I'm going to first dive in by asking each one of y'all to introduce yourselves in a little bit more depth and your organization in more detail. Dr. Mesa, can we start with you?
Wonderful. Well, thank you very much, Maria. I'm honored to be here today. And I wear a couple of hats. I'm the Executive Director at the Mesa Cancer Center at UT Health San Antonio MD Anderson. Mesa is a National Cancer Institute designated cancer center serving the people of San Antonio and South Texas, with a mission to decrease the burden of cancer in San Antonio and South Texas. And what that region is a region of almost 5 million individuals, the majority of which are Latino. So we're deeply committed to the issues from prevention, screening, therapy, and survivorship related to cancer for Latinos. As you know, there are many health disparities, and I certainly look forward to our discussion on innovations. The other hat I bring to this table is I'm on the council guiding the efforts at Genentech for advancing inclusive research. And what that means regarding having the participants in our clinical trials really look like the people that they are meant to serve, both in our community, which is a Hispanic majority community, but across the country.
Great, thank you. Dr. Stokenbrook?
Yeah, thank you so much, Maria. So my name is Robert Stephenborg. I'm a physician by training, and working as a physician, I've seen firsthand the effect that health disparities can have. This is such an important topic because Hispanics are the largest minority ethnic group in the United States. So it is critical for any organization working in healthcare to realize that the health of Hispanics is vital to the health of the nation. And at Novartis, we are committed to the development of new therapies in various disease areas, including in cardiovascular disease, that will enhance the lives of the millions of people who suffer from cardiovascular disease. I work as a medical director now on Novartis, as you mentioned, in the Cardiorenal Metabolism Unit, and I'm honored to be here. Thank you.
Great, thank you. And Dr. Offman?
Yes, hello. Hi, Maria. And I'm thrilled to be here speaking with CHCI, and it's quite an honor. I'm Josh Offman. I'm a physician by background and a health policy researcher. And I'm the Chief Medical Officer and Head of External Affairs for a company called GRAIL. And as many of you are aware, cancer is soon to become the #1 killer of men and women worldwide. It is, in fact, the leading cause of death among Hispanics today. And unfortunately, the reason why we're losing the war on cancer is because we're detecting cancer too late. And when outcomes are poor and treatments are inaccessible and ineffective. So we believe that early cancer detection is really one of the keys to dramatically improving the cancer detection rate in the population, which can then make a dent in cancer mortality. And GRAIL is a company that was started 4 years ago to tackle that enormous challenge. And so we're focused on novel genomic technology, and we've developed a test that can detect over 50 cancers with a single blood draw. And doing that with really minimizing false alarms or false positive tests, and also directing the workup to very specific tissues. So we think by adding that to existing single cancer screening tests, we have a great opportunity to address this enormous challenge of how do we bend the cancer mortality curve.
Well, thank you, Dr. Offman. And it's outstanding to have all three of you representing such esteemed organizations and companies. So I'm going to jump right into the topic at hand. Dr. Stokenbrook, the COVID-19 pandemic has highlighted the severe degree of ongoing health disparities among minority populations in the U.S. And these disparities in illness and death have amplified the need to address health equity on a systemic level. The case for advancing health equity beyond our pandemic response has never been stronger. How is your organization specifically focused on addressing these inequities to improve outcomes and achieve health equities for Latino populations and beyond?
Yeah, thank you so much for the question, Maria. And as you say, I feel like COVID highlighted disparities that have always been present. And I think it is critical not to lose momentum in addressing those inequities, even if COVID resides. I think it's important to realize that health disparities are multifactorial and super complex, and any effort to address inequities must account for those complexities. And I believe that it is important for companies that develop new therapies to consider ways to address disparities in each step of the process of bringing new drugs to patients. The way that I look at it, I always group the efforts that companies like Novartis should take into 4 buckets. So first, during the development stage, I think diversity in clinical trials is essential. And after a new therapy is available, it is obviously important to ensure that patients who might benefit from those therapies actually have access to those therapies. And addressing challenges related to adherence is another one. And the fourth one could potentially be educating physicians and patients on health disparities. So I'd like to zoom in on a couple of those. So first, clinical trial diversity. I think for any new therapy, it is essential that the population in which those therapies are studied reflect this population that will ultimately use those therapies, in part because there may be differences in the efficacy and safety and tolerability of therapies across different populations. And evidence from clinical trials inform the guidelines that physicians use when choosing therapies for individual patients. And there's a risk of providing suboptimal care if we do not recognize that one size does not fit all. Now, traditionally, randomized trials in cardiovascular therapeutics have failed to fully represent elderly patients, minority populations, and women, which challenges the integrity of our evidence-based care algorithms in clinical practice. And we take various steps to ensure that our trials are representative of the populations in which our therapies will ultimately be used. A lot of it centers around the physicians who include patients into our clinical trials. So just to give a couple of examples of the ways that we try to ensure the representativeness of our trials. So first, we typically work with big institutions who enroll the patients in our trials. And what we try to do is to have the conversation with those institutions about diversity and train investigators and hold them accountable for the populations that they enroll in their trials. So if we do not have those conversations, they will not do it. So that's why it's important that we initiate those conversations. And second, we also know that physicians with diverse backgrounds often have more diverse patient populations. And selecting those patients as investigators in our trials increases the probability that we will include diverse populations in our trials. A third thing that we do is generate reports that provide information on patient demographics at the clinical trial site to monitor diversity of trials and provide support where gaps exist. We have also noticed that the use of digital technology to advance patient recruitment in clinical trials is a good way of enhancing the diversity and participation of historically underrepresented groups. There's also something very practical. So we can mitigate barriers that patients face when they participate in clinical trials. So think about, for example, transportation challenges and scheduling conflicts and language barriers. So just to give a very, very tangible example, what typically happens is that in clinical trials, patients get reimbursed for their travel costs and things like that after they have done the study visit. But one very easy way to increase the population of the diversity in our trials and address barriers that are faced by certain populations more than in others is just to ensure that we facilitate the transportation costs and things like that for patients who might not necessarily be able to afford the upfront cost of even simple things like parking and ground transportation. So just to zoom in a little bit on the access side. So even after development, after the trials, I think very few people know that the generics and biosimilars company Sandoz is a division of Novartis. So we encourage the greater use of generics as an effective way to hold down drug spending and increase access to affordable care. And Sandoz is actually one of the largest generics and biosimilars companies in the US. And we estimate that our medicines through our Sandoz generics division have helped save the US healthcare system around $12 billion in 2018 and around $101 billion over the last decade. And we obviously believe that our medications should be available to all we need them, and that we have a responsibility to make our products available to those who cannot afford them. So in late 2017, we committed to systematically integrate access strategies into how we research, develop, and deliver our new medicines globally, and establish the Novartis access principles. And those strategies include adopting innovative pricing and access models, and refocusing research and development based on society's healthcare needs and supporting approaches to strengthen healthcare systems. We also have, for example, the Novartis Patient Assistance Foundation, and we provided approximately $2.7 billion in free medications to more than 87,000 patients across our portfolio in 2019 only. And those access programs are available to individuals making less than $75,000 a year, which increases as the family size increases. Last thing I want to touch on is our education efforts. So education for physicians and other healthcare professionals, as well as for patients, is something that Novartis devotes substantial resources to. And that education often centers around diversities and just making the physicians who treat those patients aware of the fact that those inequities exist and how they can potentially be addressed. So those are just a couple of examples of how Novartis tries to address health inequities.
No, thank you for that very robust answer. Dr. Mesa, I'm sure you agree with some of the ways they're tackling. I wanted to see if you and the organizations you're working with had anything to add to that same question around, how you all have been focused on addressing inequities and to improve outcomes.
Well, it's an excellent question, and Robert brought up, many valid points. So one, as a cancer physician, I'd say that there are a couple of key areas that are being worked on. One is clearly that those who participate in our clinical trials, where we really test new therapies to see if they're effective as well as safe, are representative of the general population. I like to use the analogy that, again, as all of us are excited about a potential vaccine for COVID, if that had only been tested in a very isolated group, let's say only on Iceland, would we all have confidence that it would be equally applicable to all of us? It might be, it may not be. There may be safety issues, there may be efficacy issues. The same is very true when it comes to medicines that deal with cancer. So I'm involved with several groups. Genentech, as I had mentioned, that has a group that really pulled together a very solid effort to really try to make a transformational change in terms of how individuals that are minorities are accrued onto cancer clinical trials. Our organization, the cancer center that I direct, We accrue over 50% Latino patients on the cancer clinical trials. And that's crucial, both as an opportunity for those individuals to be able to participate, but just as importantly, if not more so, we then have that knowledge that those therapies are either safe and or effective in that population. The second way, which is clearly a theme for today's call as well, is really around the issue of precision medicine. And it has to do both with identifying whether therapies are safe for a population in terms of how they react to it, metabolize the medication, and there are many important genetic differences. Again, even myself as a Latino, the Latino population is itself very heterogeneous. I myself am a Cuban by heritage, and that has similarities but distinct from individuals in South Texas, many of whom are of Mexican descent, individuals in California, individuals living in Mexico now, maybe a slightly different situation than individuals that have been in South Texas for many years. So genetics, both in terms of how one metabolizes therapies, but also targets in terms of genetic changes that either drive cancer or can be leveraged as cancer therapies. So I think both regarding precision medicine as well as representative trials, so that we truly know whether drugs are safe and effective, are two crucial ways to help to impact some of that health disparity.
Great, thank you. And I want to make sure I give Dr. Offman a chance to tell us how his organization is tackling the same challenges.
Sure. So thank you. I'll keep it brief. I think you're absolutely right to point out that the current pandemic is exacerbating all of this. And as it relates to cancer, it's almost creating a second pandemic. As many of you have probably read the reports, there's been a pretty precipitous drop off in people's willingness to get their routine cancer screening. And it's projected that that's going to result in tens of thousands of more deaths and up to 80,000 more late and delayed diagnosis of cancer in this country, which is really tragic. So on top of the general problem you have with cancer detection, now you have this kind of secondary effect, which is really unfortunate. And as I mentioned before, it's incredibly important to address these disparities because as cancer is the leading cause of death among Hispanics right now, it's accounting for up to 21%. And early cancer detection is one of the best opportunities we have to prevent that or to address it. So there is a role for technology here. So as you know, many people are not going to get their mammograms and they're not going to the doctors to get procedures and colonoscopies. But GRAIL has pioneered a new technology that is a simple blood test. And we hope it'll be introduced next year. It can detect over 50 cancers. And by adding that simple blood test, which can be accessed in the local community very easily without going to healthcare systems, we think it could be an important addition to these single cancer screening tests and help serve these underserved communities. The last thing we're doing at GRAIL is we do have a health disparities task force, which I chair, which is really looking into what has already been mentioned, which is the inclusion in our upcoming clinical trials to make sure we have as much diversity as possible.
Dive a bit more into GRAIL's work a little bit later in the conversation. And really, thank you to you and your companies for all of your leadership and working to tackle these disparities. So, Dr. Mesa, considering the pandemic, patients may continue to avoid care environments such as hospitals, physician offices, outpatient care facilities, and clinical trial centers even. In your opinion, how well is the industry and system prepared to support successful care? And have any of you honestly considered partnering with stakeholders within the community to assist you? And I'm going to ask the same question to the other two afterwards to see if you'll have any additional comments. But Dr. Mesa?
It's been an important area of focus. So first, our center, and I think many others have done an excellent job of making a safe care environment by decompressing the environment. So individuals that are in supportive roles that don't need to be in the building or are working remotely. People are screened, personal protective equipment, social distancing. So we never interrupted our care throughout the pandemic and have treated our patients safely, whether that was with infusion, radiation therapy, surgical procedures, etc. It has been safe, but clearly that is an important consideration with travel and other things being a barrier. I do think one of the important developments of the era of the pandemic has been the rapid adoption of telemedicine. And I do think that has ways to contribute in terms of health disparities. In South Texas, it is an enormous area with tremendous distances. And with the pandemic and pre-pandemic, issues of travel can disproportionately affect individuals, both because of time away from work, particularly if they're paid hourly, as well as the economic burden. We previously piloted using telemedicine in aspects of care, such as genetic counseling in cancer and others, with some success. But now with the pandemic and really the availability of being able to provide telemedicine, it's really made a big impact. Screening individuals for symptoms, managing toxicities during cancer therapy, having discussions regarding new symptoms with primary care providers, advancing discussions regarding cancer prevention and screening, managing people potentially on clinical trials, screening people for clinical trials that are from a greater distance to see whether travel is advisable. Telemedicine counsels to see whether travel for a resection or other thing is helpful. So I think it's helped to concentrate who are the individuals that really do need to travel some distance to receive some specialized care, but much greater support of individuals locally. So I think that has really been an important technological advance. And although there were hiccups at first in terms of individuals' access to technology, we have found at least many individuals have access to at least some form of device or computer to be able to participate in those sort of visits.
Great. No, thank you for adding that. Access to broadband in a lot of communities is always challenging, so it's a good point to make. Dr. Stokenbrook, did you have anything to add to that?
Yeah, so basically we know, of course, that the pandemic has influenced access to care, and I believe that may be particularly detrimental to patients who already have difficulty navigating our complex healthcare system. And Josh mentioned earlier that there may be an impact of the pandemic on cancer screening rates, and the same is true for cardiovascular disease. So we have seen, for example, an enormous decrease in the observed rate of heart attacks early on during COVID. Now, that is probably not because patients have fewer heart attacks, it's just because they do not seek care. And that is, of course, super alarming. I also think that, as Dr. Mesa alluded to, I think that the pandemic has accelerated the shift to telehealth, and it also provides new opportunities for new care approaches. So think about, for example, virtual prevention clinics that allow for a more systematic approach to care and could make it easier for patients to seek care. And I think one of the interesting things is that what we notice in clinical care, based on all of the data that we have, is that there are enormous differences in the quality of care across different physicians, across different hospitals, across different states. And I think that virtual care allows us to basically implement guidelines in a much more systematic ways. And there are several examples of virtual prevention clinics across different disease areas. And I believe that is really an enormous opportunity. And like I said, I think that the trend towards the adoption of that kind of strategy may be accelerated due to the pandemic.
My next question is actually going to be for you, so maybe if you want to incorporate your answer to this one, if you have any comments on it, as well as the next one, that'd be good because we have questions pouring in. So Thank you. We all know that detecting cancer in its early stage before it has spread throughout the body saves lives. And the 5-year cancer survival rate is about 89% when cancer is diagnosed earlier, compared to 21% when it's detected after it's spread. The important benefits of early cancer detection reach too few Americans. So screenings have been available for only about 5 cancers, and cancers without recommended screening account for 78% of all cancer deaths. This data makes many very excited about new technologies like GRAIL's new multi-cancer early detection blood test. Can you tell us more about this technology and specifically the role policy has in shaping how patients and populations will have access to this innovation?
That's great. Thanks. A fantastic question. Maybe just a quick comment on the prior one and just echo the thoughts of Drs. Mesa and Stokenbrook is that we know, and as I'm a health policy researcher, that we have got to make a transition in this country from a system of a break it and fix it kind of healthcare system to one that's focused on prediction, prevention, and early detection. And I think you heard both of them very articulately speak to that point. And I think, an unusual byproduct of the COVID pandemic is that we will accelerate that transition, that the focus on telemedicine, the focus on these innovative approaches to care are going to help us get there. And it fits right in with the next question about how do we dramatically improve early cancer detection in this country? We're screening today for 5 cancers. And given their compliance and given their performance, we're only detecting about 15% of the cancers in the elevated risk population of those over the age of 50. And so that's not going to do it, right? It's really important these screening tests save lives, but we need to do more. And so we're at this precipice in healthcare where we're at a revolutionary point. We can now look at the genome circulating in the blood, and we can detect signatures for cancer and for where in the body that cancer signal is coming from. And this is because we've had this enormous growth in and technological innovation in the human genomics and in machine learning and artificial intelligence. And the confluence of those technological trends has resulted in the fact that a company like GRAIL can be born and actually develop a technology based on tiny bits of DNA that are floating around in the blood. And the reason that happens is cancer cells are growing and turning over and dying, and they're shedding little bits of cancer into the blood. So now we can find those little bits of DNA in the blood, and we can sequence it, and we can look at these signals and signatures in the DNA that are very specific for cancer. And so it's enormous opportunity. The Gallery test that we've developed, which hopefully will be available next year, can detect over 50 types of cancer. And we have to do that while minimizing harms. And the biggest harms associated with cancer screening are false positives. And I think most women have been through some harrowing experience of a false positive mammogram, for example. Mammography is a wonderful test, but it does have a lot of false positives. So we've kept that false positive rate less than 1%, which is a pretty impressive finding for looking for 50 cancers. And the other thing is there's a concern that maybe we're detecting cancers that don't matter, the ones that aren't going to harm people. And it looks, because of the way we're finding cancer by looking at the DNA in the blood, it doesn't appear that we're going to contribute to the problem of overdiagnosis. So I think we can detect cancer, dramatically improve the cancer detection rate in the population, and do that while minimizing harms. And we think that's the best opportunity to bend the cancer mortality curve. To your question about policy, there are some big challenges here. Medicare, as you know, does not currently cover screening tests. And the only reason we have coverage for things like mammography and colon cancer screening and prostate cancer screening is because legislation was introduced to specifically charge Medicare with providing coverage for those screening tests. And so, we need absolutely to, and I know there are a lot of people in Washington working on modernizing Medicare, but this is a huge area of focus for policymakers and advocacy organizations to think about how can we provide a benefit for individuals to cover this new generation of innovative technology, which will allow us to do what we call multi-cancer early detection. And so it's really a dramatic need that we have, and particularly if we want to ever hope to serve these underserved communities.
Can say is one of the many women that have had a false positive and had a very scary 4 to 6 week period of time. Technology like yours definitely brings hope and a little bit more peace of mind. I'm going to pivot a little bit over to Dr. Mesa again to talk about adherence a bit. So adherence is a growing concern for physicians and healthcare systems. There is increasing evidence of noncompliance among patients and correlated adverse outcomes that follow. Can you tell us a bit more about adherence and how new innovations in technology support patients in their adherence to therapies?
Well, I think adherence really is part of the broader discussion regarding, patient education and overcoming many aspects that can relate to culture, can relate to language, can relate to kind of pre-existing biases. So whether that's adherence to procedures, for screening, again, reluctance to have mammography or colonoscopy or other things of that nature, adherence to medications, whether it be for medications for diabetes or hypertension, dietary adherence. We know obesity playing a very significant role in the development of cancer and cardiovascular disease, and certainly many areas of innovation of how we're communicating with patients with each of those through their devices, through texting, through improved communication platforms, whether it be through face-to-face interactions, even remotely, like promotoras, which have been a variety of different pilots for individuals interacting with individuals of the same language and culture for trying to promote various aspects of health benefits. One of my colleagues here in San Antonio, Emily Ramirez, who's a national leader in cancer research, she had a very innovative trial called Quit Text, where they were looking at a text-based way to communicate with young individuals to promote smoking cessation, and had a 21% rate of smoking cessation with this texting-based approach for really encouraging individuals to have a smoking cessation and really try to maintain those behaviors. So I'm excited about the whole range of the technologic aspects, both the very exciting impact that liquid biopsy and the efforts of Josh and his colleagues are helping to move forward. I do think that has the potential to help us tremendously. But as you might imagine, there could be some significant both cultural issues and language issues in terms of both agreeing to have that sort of testing as well as reacting to the results of those tests.
Great, thank you. Dr. Stokenbrook, anything to add?
Yeah, I think the success of many currently available therapies relies on patient self-administration, obviously. So whether that is taking a pill or injecting yourself with a subcutaneous injection, for example, insulin. And we know that adherence is a big problem that actually disproportionately affects certain populations. And language barriers, knowledge of health and disease, and financial aspects all play a role in that problem. So just if I think about the efforts that we are doing to address this problem, I can give you a couple of examples. So for many of our therapies, we develop patient support services that provide opportunities for patient education on their disease and help them stay adherent to their therapies, not just our therapies, but also other therapies that a patient is on and that they would benefit from. We are also investing in the development of therapies for chronic conditions with infrequent dosing regimens, which can potentially offer adherence benefits compared to daily pills, and even allow for administration by healthcare professionals, so that you can basically circumvent that problem related to patients' self-administration altogether. And a last point that I would like to make is that I believe that technologies, as Dr. Mesa alluded to, really have the potential to improve adherence. So, for example, we are exploring ways of improving adherence through smartphone apps. And just to give a brief example of something that I'm very closely involved in, is we are currently evaluating a trial where we will be combining one of our therapies with an app that will basically support patients' adherence to therapy. And again, not just our therapies, but also other therapies that a patient may benefit from. And I believe that I mentioned that trial because I believe that medicine drives and changes on evidence. And I believe that a big part of making change in this area and leveraging new technologies is to deliver the proof that it actually works. So that is something that I think is really important that we are working on.
Yes, and I continue to hope that with COVID happening, people understand that science constantly evolves as we continue to learn more. So thank you for that. And we do have an audience question I think is relevant at this point that I'll invite any of y'all to chime in on. How can patients talk to their healthcare provider about new technologies and what tests they receive? Do any of y'all have any advice how they can approach their providers?
Sure, maybe I'll take a stab at it. Obviously is getting informed as possible, on the new technologies, and just really actually insist that you get the technologies that you deserve. And unfortunately, part of the adherence problem and part of the technology problem is this idea that there's a lack of coverage for new medical technology, both in the private insurance market and in Medicare. And we feel that we now have new technology that's a simple blood test, which can actually really help provide access to underserved communities and those that are non-compliant with these interventional procedures. And it just should be unacceptable at this point that we have the technology, the science is here, yet we're allowing people to walk around with deadly cancers in their body when they don't know they have it. And we're waiting for them to be diagnosed with cancer before we'll pay or cover services, diagnostic services or therapies. So that should just be something that patients see as unacceptable, and we need to work with our policymakers to rectify that. And in the process, we can improve this problem with compliance and adherence with this kind of new technology, like a simple blood test.
Certainly. Thank you. Dr. Mesa, did you have something to add?
I did.
I saw you put your hand up.
Yes. The issue of later stage presentation of cancers is a major challenge, and I think it disproportionately affects both Latino patients and many who are underserved. It's only been heightened really during this time of the pandemic where people were lack of prevention or screening or had symptoms potentially that could be a sign of cancer going in. So I think there clearly is an important social justice reason why we do this, but there is a strong economic case. Cancer is still going to show up. It's still going to need care, but the likelihood of success and likelihood the amount of resources, kind of healthcare resources that an individual with an advanced cancer is going to need is tremendously more than if we catch it at a much earlier stage of disease, both much more impactful for the individual, but clearly likely a much more efficient and cost-effective way to care for that cancer.
Thank you. That's great. And I would just add, as patients try to speak to their community, their doctors and their caretakers about, tackling whatever their disease they might be living with, to take advantage of advocacy organizations within their community and their state. They're easily found online, and those types of advocates, whether it's a diabetes group or a cancer group or anything really, there usually is some sort of organization that can help teach you how to communicate with your caretaker and your providers. So I just want to put that out as something for the community to consider. We do have quite a few questions coming in. What is there anything more, Dr. Offman, that you think the industry can do to advance the science of patient input and ensure new technologies and treatments align with patient needs? And Dr. Stokenbrook, I'm going to ask you the same question.
Yeah, I think, our industry has improved over the last decade in soliciting patient input, focusing on patient-reported outcomes, looking carefully at patient preferences, and actually getting patient groups involved in clinical study and clinical program design. So I think there's been a real leap forward from our industry, but there's always more we can do. And we need to stay very engaged with patients to fully understand their needs and their and get input early in the process as we develop our technology, as we develop our medicines, and as we develop our studies. And then finally, as has already been mentioned, we need to make sure those studies are well represented by the different ethnic groups and underserved communities. And I think together, those can make a big impact.
Dr. Stokenbrook.
Yeah, I totally agree with everything Dr. Offman said. The way that I often think about this is that it's basically all about asking the right questions throughout the process of development of whether that is a drug or a new technology. And I think it even starts as early as selecting the therapies that you will develop or the technologies that you will develop, and basically focusing on well, in my case, on therapies, on drugs for diseases where there's a high unmet medical need and a high impact on a patient's quality of life. And then subsequently, when you're thinking about how to develop that drug and what type of studies to do, I think it's important to focus on implementation studies to basically deliver results that are directly applicable to routine clinical care, and therefore provide the most value to both patients and healthcare professionals when they make treatment decisions, and to patients in terms of the what actually works in a routine care setting rather than in the highly artificial setting of a placebo-controlled double-blind trial. I think the next step is as Dr. Offman also alluded to, incorporating patient feedback in the design of the trials. So, for example, having patient advisory boards when designing a study and getting very practical input from patients, not just on things like the wording in the informed consent form, but also in choosing patient-relevant outcomes. And lastly, also as Dr. Offman also alluded to, is capturing patient-reported outcomes to evaluate the impact of new therapies or new technologies on quality of life and various other measures that are important to patients. So those are some of the things that are on my mind.
Great, thank you. So we're not quite up at time, but I want to make sure we acknowledge, get to some of the questions that have come in. So Dr. Mesa, I have a final question for you, and I'm going to tie in one of the top questions we're getting from the audience. The metabolic syndrome is leading to disproportional levels of many diseases in Latino populations. There is a wide range of policy implications surrounding this. What is the role and status of policy, and what can policymakers what can they do about equitable access to treatments, vaccines, and other new safe innovations? And I would ask that if you could even touch on how the public and private sector might be able to work together to incentivize innovation, potentially in this answer.
Well, it's very true that the metabolic syndrome is a major driver of many of the diseases that we're facing. The National Cancer Institute certainly has on its radar that obesity either has or soon will surpass tobacco as the most, let's say, preventable cause of cancer. One of the most sobering aspects of that is it's being found that obesity in children, potentially can turn on pro-cancer signals that are not easily reversed, even if that individual then loses weight kind of as they become an adult. So I think there are many implications in terms of health policy as it relates to drivers of the metabolic syndrome, obesity, education, implications particularly in terms of children and the education and other resources that need to be involved with that. Increasingly, we know vaccinations are important strategies as well, particularly as it relates to cancer, the HPV vaccination, and both policy coverage, but educational gaps that exist for underutilization of vaccines like that make major implications in terms of cancer prevention. In our region, we have some of the lowest rates of utilization of the HPV vaccination in the United States. And that is for a range of reasons, not the least of which are many barriers of perception that the HPV vaccination is somehow an endorsement of promiscuity amongst young individuals. So many barriers, but it's going to take a tremendous amount of teamwork. These are not easy things to fix. I think if there were an easy fix for obesity or the metabolic syndrome, we probably would have had it a long time ago. So it's going to take a tremendous amount of effort and teamwork, in that the drivers of it are really quite complex.
Definitely. Dr. Offman, can you, how can the public and private sector work together to fully incentivize innovation in the healthcare sector? If you could address that too. I think Dr. Mesa, yeah.
Yeah, and I agree with what Dr. Mesa said. I think there are real opportunities for collaborative efforts. For example, developing a consortium for multi-cancer early detection, working with the various stakeholders, kind of bringing together the collective group of champions for a very particular issue is probably a really powerful way. I think if you do that, you can then focus on education, advocacy, and policy. And obviously, we need to modernize our healthcare system to focus on prediction, prevention, and early detection. And we're never going to make that transition if we don't even provide basic coverage for those types of things. So we need to bring our voices together, and we need to influence the policy process to make sure that we can take advantage of technologies that are available today, that if we put them into practice could really help bend the mortality curve, particularly for cancer. And so there are collective efforts that I think are critically important, and we need to get moving on them. And GRAIL's very committed to doing that. Those can be public-private partnerships, or they can be consortia of important stakeholders.
Definitely. Dr. Stokenbrook, Latinos represent less than 5% of clinical trials. How can the healthcare sector encourage Latinos to participate in innovative treatments? I know we've touched on this some, but if you have anything to add, that'd be great.
Yeah, I think it is such an important topic, and like I said, I touched on it before. I think a lot of the responsibility should reside at the level where patients are actually included in clinical trials. So I think having the conversation with those institutions and with those physicians who select patients for clinical trials is really where it all should start. And I think it's a matter of holding accountable the right people. So that includes both the physicians who enroll patients, and it also includes companies that develop new therapies. And one of the examples that I gave before, and I think that is just a critical one, is that we know that physicians with different backgrounds often take care of populations with the same background. So, for example, an African American physician might have a higher proportion of African American patients, and the same goes for Hispanic physicians. And I think that selecting those physicians as potential investigators in studies, rather than the traditional approach of just including the big institutions, is a very important way of increasing diversity in clinical trials.
We actually only have about 8 minutes left, so I'm going to invite each of you to give your some closing remarks, any final comments. I would ask that if we try and answer a couple questions in the closing remarks, that would be great. Two of those two items are, if you're able to touch on any future innovations that you may have heard of that could be promising to the Latino community, and how could CHCI use their platform to ensure better investment and resources for Latino health issues, in your closing comments. So I'm going to go with Dr. Mesa.
So first, I'm very excited to have participated on this panel. I think that innovating to try to decrease the morbidity that Latino patients face is very important. I think the CHCI is really able to advocate in a way as it regards to health policy, to both ensure that how we learn about these diseases and how we implement solutions is really done so across the board. That certainly includes genetic testing and precision medicine, but I think even much more broadly, as we think about the inclusion of Latino patients in every aspect of what we're studying, through prevention and screening, whether that be through how we're testing liquid biopsy or how those things are being adopted. I think there's both technologies, but really getting them in the right hands of the right people, how they're utilized, and having them accepted by the cultures is clearly part of that. clearly includes treatment trials, whether that be in cancer, cardiovascular, or in Alzheimer's disease, and clearly includes in the aspects of survivorship. In cancer, we know that there are tremendous challenges that individuals that have had cancer as part of their life's journey face, and overcoming those has tremendous long-term implications for their health. So as I work with many organizations, Genentech, BMS, the Leukemia and Lymphoma Society, and others, as I look at health equity, think about treatment studies, but it's really much broader than that. We need to really be thinking about how we study health through survivorship, and having that really be reflective of our population.
Great, thank you so much. Dr. Stokenbrook, do you want to same questions?
Yeah. So basically, I think what you've heard us describe and is that the when we think about addressing health disparities among Hispanics, it all starts with selecting the technologies or the therapies that meet the needs of the individual population, and it's about recognizing that one size does not fit all, so that the demands of Hispanics may be very different than the demands of other populations, and making sure that you develop solutions that address the needs of all of those people and tailor the solutions. And then subsequently, during the development stages, ensure that you test the new technologies in the population that will ultimately potentially benefit from those technologies and treatment innovations. And that is, of course, not where it ends, because subsequently the big challenge is getting the right therapy or the right technology to the right patient. And I think that we all have to ensure, and we all have to work together to ensure that that healthcare professionals are aware of the diversity and health inequities, so that they are able to address them. I also just lastly wanted to touch on a point that I think is something that that legislators can potentially do. I think it's important to have action plans on a state level to address some of these inequities. So, for example, a cardiovascular plan that provides very, very clear guidance on how cardiovascular disease inequities can be addressed on a state level. And I think the same can be true for cancer and for many other disease areas. So I'm going to leave it at that.
Thank you so much. And finally, Dr. Offman, any final comments and, for those other questions?
Sure.
Anyway, how CHCI use their platform? Sure, go ahead.
Well, again, just feel very privileged to be here today to be able to address the caucus, and again remind everybody here that we're enormously focused on addressing these disparities. That cancer is the leading cause of death among Hispanics, and Hispanics are unfortunately much more likely to be diagnosed with advanced cancer than early cancer than their non-Hispanic white counterparts, and so it's very challenging. And so we have this enormous opportunity that sits before us. If you think about the investments we've made in the United States, dating back to Richard Nixon's initiation of the war on cancer, and then Vice President Biden's cancer moonshot and the Human Genome Project, we spent billions of dollars on the Human Genome Project, and this technology is now ready to be used. And in fact, early cancer detection, these multi-cancer early detection tests using the genomic information may be the first population-wide application of the Human Genome Project. And so we're at this incredible inflection point where we may be able to serve these communities with much more simple, specific, and effective testing to hopefully change those statistics. But we do need the community to advocate, because policies need to be modernized and we need to provide access to this technology. And it's just not feasible to wait 10 to 15 years for mortality studies to be done on every single cancer one at a time, when we know we have technology now that can detect multiple cancers at earlier stages.
Well, thank you. I think it's a very positive note to end on. And thank you all of our wonderful panelists, Dr. Mesa, Dr. Stokenbrook, and Dr. Offman. I think you provided some excellent guidance for us today, some inspiring words and some hope to patients, of course. So I would just say, one of the biggest takeaways I hear from this at a high level is collaboration and coordination is really key to continue to make strides here, not only to advance policy, but also, of course, to bring better care and cures to patients. And COVID is an opportunity to continue to work on enhancing the systemic change problems we have in our system to achieving that. So with that, I'd like to encourage all of our attendees to please keep tweeting about the Health Summit at hashtag CHCI Summit. And we encourage you to attend our afternoon plenary session today addressing social determinants of health in Latino children, youth, and families today at 3:30. So if you know anyone interested, if you know any people who would be interested in the Health Summit, please encourage them to register at chci.org. And thank you again to our panelists and the team at CHCI.